Batch already knows you.
Yeah.
Can give some basic
Right.
introduction.
Thanks a lot, sir. Thank you very much. So, hi friends. I suppose my screen is visible and everything is
You have
fine.
to make it full screen.
Okay, sir. Just a minute. I'll just get back. I'll just get back. Just a minute. I suppose now it's fine, sir. Correct?
Yes.
Thanks a lot. Right. So, hi all. Good evening. So today we'll be launching our advanced flow cytometry course, which will be, I promise you, will be more interesting and it will keep you engaged. So we have already, some participants have attended the basic flow cytometry course, and now this is advanced, and as the name says, this is advanced, so not much of basics will be dealt in this course. We'll be dealing much of role of flow cytometry in hematological malignancies, especially leukemia, lymphomas, and myelomas. Okay, we'll also be discussing detection of MRD in leukemias and myelomas. That is also a part, and this is how I have structured this particular course, and I've also shared the schedule of these lectures in our WhatsApp group. So we'll have part 1, part 2, part 3, each taking like 4 lectures, and it will be there for a month. So we have a 3 months course running from today, and I have already shared the schedule with you all. So it's going to be very interesting. I promise you that. That is, so it will keep you engaged, and you will really develop interest in flow cytometry. And many people will be starting to do immunophenotyping and MRDs in future. I'm very sure with that. Now, so to introduce myself, I'm Dr. Tulsi Raman. I am a hematopathologist with 10 years of experience and 7 years of flow cytometry experience. I work for Apollo Hospitals, Chennai, and I published some papers. I'm there in Twitter, so you can see my cases, my publications there in ORCID, so and so, which I'll share it in the thank you slide. So you can just, if you want to check out those, you can have. And before I start this session, I would want to tell some things to the participants. I request the participants to be as possible to be not in very formal way. You can be very interactive. Feel free. Ask me doubts when you're not understanding things. Don't feel shy, because here this is an opportunity for us to learn, to interact. Okay. So when you have a doubt, please stop me there, and I will be very happy to take up your questions. Okay. Anyhow, I'll be giving breaks during my session, and you can ask your doubts during the break, or you can type it in the chat box so that I can take your questions. So whenever I see it popping up. So that is one. Second is, though there is a recording lectures available, I want the participants try to attend the live session, because it makes it more interactive, and you can ask your doubts, and understanding is very better when you are attending a live session than just seeing a recorded session. Okay, so today is just an introduction where I'll be discussing on the role of flow cytometry in various aspects of hematological malignancies with a beautiful case-based discussion. And from next week, we'll be going into the core of immunophenotyping in leukemias. Okay. So to start with, initially it was all the diagnosis of hematological malignancies was based on clinical features, blood count, morphology, and cytochemistry. Right. Of course, if you take 15 to 20 years back, the cases were diagnosed basically only by these findings, like whether you get a total count, a morphology, or cytochemistry at the maximum. But now the things have changed a lot. You have auxiliary techniques, and now we are standing in a point where it is inevitable to give a good diagnosis without these auxiliary techniques. So if you want a proper diagnosis to be made for an hematological malignancy, you definitely need immunophenotyping, you definitely need cytogenetics, and some cases you need molecular genetics too. Then only you can correctly place that particular diagnosis as per the blue book, WHO. Okay, if you are not doing these auxiliary techniques, diagnosing only by morphology and cytochemistry and other findings may not give you the proper diagnosis. Okay, everything matters, and as you all know, we will be discussing on immunophenotyping, that is flow cytometry. Immunophenotyping by flow cytometry is what I will be discussing, and I will be taking you through for the next 3 months. Okay, I say it again, it will be very interesting. Mark my words, after 3 months, I'm very sure that you will all start doing immunophenotyping if you get an opportunity. Okay, so as I said, this is an advanced course, and I'll not be discussing much of basics. We have another basic course which is running, but this is advanced, so I'll not take much time to discuss basics. But just to make it very short, so what is the principle of flow cytometry? So flow cytometry is a technique where we use an antibody which is tagged to a fluorochrome, and when you add this antibody will go and bind to this antigen which is present on the cell. So this is the target antigen we want to study, and we use a complementary antibody which is tagged to a fluorochrome. This is called staining in flow cytometry. Okay. Now, when such a stained cell is made to run through a flow cytometer, okay, what happens? For example, now let me show you. So this is a stained cell. Okay, and when you make it to run through a flow cytometer, the laser hits the cell and you get scatter light as well as fluorescent light. The scatter light is because of the physical property of the cell, which is the size and the internal complexity, that is granularity, and fluorescent is based on the fluorochromes which are attached to the cell via the antibody. Okay, so you get scatter and fluorescent signals which will be collected by the detectors, and you get the data. Okay, so this is a schematic representation of data analysis where you have a blue fluorescence in the y-axis and red fluorescence in the x-axis. So you know how to read this. So if your population is falling here, it is double negative. If it is falling here, it is positive for the y-axis marker. If it is falling here, it is positive for both y-axis and x-axis marker. And if it is falling here, it is positive only for the x-axis marker. Okay, so this is the instrumentation of a flow cytometry. So as I said, we have a light source, which is the laser, which is commonly used in all the flow cytometers nowadays. So this light source will hit the cell which is flowing in the stained cells which are flowing in the flow chamber. Okay, so when such a light source is hitting a cell which is flowing in the flow chamber in a single file pattern, because of hydrodynamic focusing happening because of the fluidics or the sheath fluid which is flowing on around the cells. Sheath fluid which is flowing around the cells. So when such a laser beam hits a cell, as I said to you, there will be a scatter light as well as a fluorescent light. Scatter light is because of the physical property of the cell, which includes forward scatter, which will tell you about the size of the cell, and side scatter, which will tell you about the internal complexity of the cell. Then you have fluorescence, which is coming because of the fluorochromes which are attached to the cell by the antibodies. Okay, so all these will be collected, filtered by the optical system, which includes the band pass filters, long pass and the short pass filters, and such filtered light will be collected by the detectors, and it will be converted to data by electronics. So this is just a brief outline of how a flow cytometer works. Okay, and the interpretation of markers. So those who have attended basics, I would have told you. Now, how to interpret a flow cytometry marker is, so always you need to interpret the markers of a target population with respect to the internal controls. You have an internal control. For example, I have shown here a T lymphocyte which is negative for 19 as a negative control, and a blue color population which is positive for CD19 as a positive internal control. So we have a negative internal control and a positive internal control. Let's assume that there is a blast population. If the blast population is lying here, it is negative for CD19 because it is lying along with the negative population. Okay. If the same blast is lying along with the positive internal control, it is positive for the population, and you call this as moderate expression. Okay, moderate expression. Now, if the same blast is falling much higher intensity than the normal internal positive internal control, then you call it as bright. Okay, so when it is falling, you call this as moderate, which is as the same intensity of the positive internal control. When it is much brighter than this, you call it as bright. Okay, then you have a population which is lying in between the positive internal control and the negative internal control. Then you call this population as dim. Then you have if the blast is falling in a very heterogeneous fashion, that is, it is traversing from the negative population area to the positive internal control area, then you call this as variable or heterogeneous. Okay, so, and then if you find blast in two subsets, that is one subset falling in the negative region and one subset falling in the positive region in a dim fashion, you call this as partial expression. Okay, so these are the terms you should use when you are expressing a marker, for a blast. For example, CD19, we have many B cell markers, myeloid markers, T cell markers. So whenever you are expressing these markers in the neoplastic population, you should use these terms in flow cytometry. Okay, so this is how you need to interpret or express the markers in the neoplastic population or the population of interest. Okay, now coming to the core of today's topic, why flow cytometry is needed. Okay, why flow cytometry is needed in hematological malignancies. So I want to take you through this particular lecture in a case-based manner so that you understand why it is so useful. Right, let's go. So now, if you find a morphology like this, okay, we don't have any difficulty. Almost everyone would say this is a myeloid leukemia, and almost 75% to 80% people would say this is APML hypergranular variant. Okay, so when the morphology is so classical, so clear-cut, that's easy. But let me tell you, when you get a morphology like this, okay, and by morphology you may call this more looks like a lymphoid. You say, sir, morphologically it looks like lymphoid. Okay, there are blasts, but morphologically it looks like lymphoid. But the confidence level is not that 100% as we saw with the previous image of APML. Okay, now if you say it is lymphoid, is it B lymphoid or T lymphoid blast? Again, a question rises there. Okay, fine, but still you said it lymphoid. We'll take that. Now, when you get a morphology like this, now there's a bit of ambiguity. Some people call this as looks lymphoid, whereas some other people would call this as could be myeloid. Let's do a cytochemistry. Is that what they say? So we are not very confident with some morphologies. Okay. Now let's see some cases. Now this is a case of thrombocytopenia. The patient had thrombocytopenia and the marrow was done. Marrow was showing a picture like this. Okay. You are finding large cells with very condensed chromatin. 1, 2, 3, of course 4, 5. Very scant cytoplasm. A medium-sized cell with very scant cytoplasm, very condensed chromatin. So many cells are there, of course. And there is also one more cell which is slightly opened up chromatin with nucleoli. And of course there are many 1, 2, 3, 4, 5, 6, 7, 8. A lot of these cells. So what are these? By morphology, anyone wants to take it up? Anyone? Should I unmute anyone? If you want to answer, you can just put it in the chat box, or you can unmute yourself and you can say.
Sir, some are myeloid, some looks lymphoid.
Perfect.
The one
Perfect.
on 8, it is of myeloid. The left
Great, great. I completely agree with you, Dr. Ariverson. This looks more of myeloid, and this all looks like lymphoid. But what would you sign this as?
acute leuk.
Very good. Of course, nothing wrong, because even I would definitely do if a chance is given. But let's see what this turned out to be. Now we did flow for this case since there were large cells like this, and you know what? This turned out to be hematogones. Okay. Remember me, in cases of ITP, in cases of infant less than 1 year, in cases of regenerating marrows, you tend to find a lot of these populations which are normal B cell precursors. Okay. And how do I confirm that? By flow cytometry. Okay. Skipping flow cytometry, just by morphology, you find these particular population greater than 20% and you want to go directly to cytogenetics, directly to molecular, you will end up AOL. You don't know where you're going. Everything will come back negative. So this is normal hematogones and you can see the beautiful maturation pattern. Okay. This one I'll be dealing in detail during our MRD session. See, most of the images, most of the things what I'm going to show now may be very new to you, and don't get panic because this is an introduction class. I want to show you a glimpse of everything. So I'll be showing you. Of course, I'll be taking in depth in subsequent sessions. So just enjoy. Don't get panic. Oh, what is this? Is going so fast. I didn't understand that. No problem. Because this is a very introduction class. I'll just take you through a breeze. That's it. Okay. So this is normal hematogones where you can see the beautiful maturation patterns. Okay. So the red one is the stage 1 hematogones. The blue is the stage 2 hematogones, and the green is the stage 3 or the mature B cells. And you see the beautiful maturation pattern. Normally in acute leukemia, you will not get a maturation pattern like this. This is called a waterfall. They have multiple patterns. Those things I'll discuss during MRD. Okay. So this is the flow showed robust hematogones. So it is nothing. It's a case of ITP with robust hematogones or increased hematogones. So it's not at all an acute leukemia. Okay. So that is the beauty of flow. Let's go for the second case now. So this is the second case where we found circulating blasts like this. Of course, yes, there are blasts. So what is this? Lymphoid, myeloid. Anyone? You can unmute. See, I'm telling you again, be as easy as possible. I'm not a big guy. I'm not. So it's you're also. I'm not seeing you also. So you can tell whatever comes through your mind. We are all learning here, so no problem. Yes, lymphoid or myeloid?
Myeloid.
Myeloid, perfect. So everyone agree with myeloid? Any difference of opinion?
Some grooves are there.
Yeah, there are some grooves, correct? And it's not that punched out nucleoli of myeloid. It could be anything. I would call that. It can. If I need to sign off morphology, I will not comment anything on myeloid or lymphoid. Of course, most of us will not comment. So what it turned out to be, let's see. Now we did phenotyping for this case. So there were a population which was lying in the blast gate. This is called the blast gate, which is the CD45 dim area. Okay. So normally this is lymphocyte, which is CD45 bright population, and this one we call it as blast gate, which is CD45 dim, because normally in acute leukemias or in the dictum is, as a cell is immature, 45 will be low. As a cell matures, 45 will be gained. So whenever a cell is immature, it has a dim CD45. Okay, so this is a population which is of interest, which has been gated and seen in the blast gate. Normally, my style is I would give red color to the blasts. Okay, so whenever you are finding something in red, that is a blast population. So there is a population in the blast gate. Okay, and I also highlighted a control, which is the lymphocyte. Now, if you see the markers, it is positive for 34. So 34 is a precursor marker. So this is definitely a blast population. Okay, so we are finding blast. So it's acute leukemia. Now let's see the markers. It is negative for 20. It is negative for 19. So it is not a B cell. It is negative for 33, but it is faintly positive for 30. So now what is the diagnosis?
So myeloid series.
Okay. It's a myeloid, but you need to tell that it's a myeloid with minimal differentiation. To call it as AML, there is something called undifferentiated leukemia. There is AML minimal differentiation. Then you get acute myeloid leukemia. Okay, there is a criteria by immunophenotyping when to call undifferentiated, when to call minimal differentiation, and when to call it as AML with FAB subtyping. Okay, the criteria is this case, the blast was showing only one marker. If you want to give it as AML, at least you need more than one marker. Because this case was negative for cytoplasmic MPO, it was negative for all other myeloid markers. Of course, it was negative for T cell markers also. So the exact diagnosis AML with minimal differentiation, and it was cyto MPO negative. Yes.
Sir, CD1, sir.
Why you want CD1A?
ETPLL.
See, ETPLL criteria is there. Anyhow, I'll be discussing in TLL class. I'll tell you what. I said CD7 is negative.
Oh.
Okay, ETP by definition, it should be CD7 positive. You can't have an ETPLL with CD7 negativity.
Yes, sir.
Okay, and of course, you know ETPLL, 1A should be negative, 8 should be negative. Those all I'll discuss in the classes. Okay, anyhow, I'll be covering it. Okay, now let's go for case 3. Similar peripheral blood, I had a lot of these cells. Okay, cells are large, there is some cleaving, convolutions. Yes, morphological diagnosis. Sorry?
Myelomonocytic, sir.
Myelomonocytic. Perfect. Yeah, perfect. Very good, very good. I appreciate that. Blasts are very large, so monoblastic appearance. Perfect. I'm very happy with that. Superb. So, even we thought, we just went in with panel, and this is what we got. Okay. So, we have a blast population here. And, we have a population here, which is positive for CD19. It is DIM positive for CD5. Okay, so this is the population we are talking about, the neoplastic population. These are the controls. Okay, this is T cells, this is B, this is the other cells, other NK cells possibly. So this is the population which is neoplastic, okay, which is positive for CD5 in a dim fashion, and it is positive for CD19. It is negative for CD23. It is positive for FMC7 in a variable or a heterogeneous fashion. It is positive for CD20, okay, and it is FMC7 positive. It is kappa negative, lambda positive, okay, and it is CD45 bright. That is, it is falling along with the lymphocytes. You can see the T cells.
Lymphoma.
Lymphoma. What lymphoma is that?
B cell.
Any wild-
B cell.
Is there a blastoid mantle or CD5 positive DLT?
Yeah, perfect. This is a blastoid mantle cell lymphoma, blastoid variant of mantle cell lymphoma. Classic phenotype, 5 positive, 23 negative, FMC7 positive. FMC7 is something comes positive in mantle cell lymphoma. It is 20 moderate expression. It is lambda positive, kappa negative, and this is mantle cell lymphoma. So, not all that appear plastic are not immature. Okay, so if you find blast, it's not immature. It could be still blastoid variant of mature CLPDs. Now, this is again a 3-year-old male child, and this was a BMA cytology. So we had a case where it was referred to us saying like acute leukemia from an other center. We got this particular marrow and we did phenotyping. Okay, anyone wants to go ahead with morphology? Come on.
Chromatin is kind of sieve-like chromatin, sir.
Perfect.
Otherwise, I don't feel it.
Since I am in the questioning end, it means like I got all these things right on morphology. Even I had problems with morphology. Okay, so even I thought like, okay, because we made a smear, it was some atypical cells. See, the advantage of having flow is that sometimes you become very lazy. You will not concentrate much with morphology. I'll tell you what. Because since I'm very interested in flow, whenever I see blast or large cells, I'd say like, okay, come on, proceed with flow. Let's see in flow. I would say that the guy who doesn't have flow will be better in morphology than me. Okay, but still you need flow. That is a different story. But still, so what would be this? Some vague diagnosis?
Either blast or small round cell tumor.
Super. So we just went ahead with flow. Flow showed this. Flow showed the complete population was CD45 negative. The blue color population was the neoplastic cells. It had high forward scatter, which means like the cells are larger. Very large cells. It is completely negative for CD45. It is bright positive for CD56. Okay, and it had some partial positivity for CD15 in a subset fashion. It was negative for CD30. It was negative for HLA-DR. And this is a classic immunophenotype of neuroblastoma. Okay, what happens is when you get a marrow and you find the metastatic deposits in aggregates, you can pick up the diagnosis. This case was sent in a tube to us, in an EDTA tube, and the cells were non-cohesive. It was all individually scattered. And we thought, yeah, it could be Luke, and we proceeded with flow, and we had this pattern. Then I went back and saw the morphology. You can find this neuropil, right? That fibrillary material. Then we said like, no. Then we asked the clinician, have you done an ultrasound abdomen? Then they found a large mass in the abdomen, and it turned out to be neuroblastoma, poorly differentiated. So that is beauty of flow. Sometimes flow can help you to pick up non-hematopoietic malignancies also. Now we diagnosed a case of neuroendocrine differentiating tumor, which is metastasis to the marrow. So that is so beautiful. Okay, and again one more case. See, if you show this case for a postgraduate, you would say, sir, this looks like an L3 blast. It could be Burkitt. Okay, but this case we did phenotyping and it turned out to be cortical DALL. Okay, and I've seen these vacuoles even in DALL in many other cases also. So vacuoles, it's not very specific for Burkitt. You can see it in other leukemias also. Okay, and this was cortical DALL. Yes. Now let's go with this case. This is a bone marrow aspirate, and I suppose nobody has a difficulty in identifying these cells. These cells were increased. So we thought like this could be a plasma cell dyscrasia and of course a myeloma, and we did with flow. The plasma cells, if I'm not wrong, this is a case of some chronic something, and the plasma cells are around 16%. We did flow. This is the plasma cell population which is showing bright 38 and 138. We gated it. It is positive for 19. And when I checked with clonality using kappa lambda, it was splitting into 2. So it is a polyclonal plasma cell. And the same through another gating, another tube. Again, you can see the population splitting between kappa and lambda. So this is reactive plasmacytosis. So flow also helps you to check clonality in myelomas in mature CLPDs. Initially, we were not having that luxury of checking clonality in TCLPDs because we don't have a surrogate marker like kappa lambda in TCLPDs, in T cells. But now TRBC1 has come, which is very good, very good. I'll show you during our TCLPD sessions. So after the arrival of TRBC1 marker, now even we can say clonality in T cell lymphomas and T cell malignancies, mature T cell malignancies. So that is the beauty of flow. You can also tell about the clonality of the population. Okay, so this is our paper what we published very long time back. So I just showed you because of this morphology. So this is a case where we found cells like this, very, very lobulated, bizarre looking cells. And then we did flow, it was myeloma. So this is an anaplastic myeloma, which was there. So my point is, with all these cases is, appearances are often deceiving. Morphology can deceive you sometimes, and you need flow to confirm it or to ensure that you're not missing anything. Or your diagnosis goes wrong, everything goes wrong. If your diagnosis is wrong, what's the point of giving a superb treatment? So you should be very careful when you're diagnosing the cases. So flow is very, very handy and useful for that. Okay. Now, so why you need flow cytometry? Basically, you need flow cytometry for establishing a very strong diagnosis. So identification, quantification, and lineage assignment to neoplastic cells or the blast. Okay. It is also useful in establishing the clonality in mature lymphoid neoplasms and even in plasma cell dyscrasias. Okay. So, and apart from putting the lineage assignment, it will also tell you about certain other things which we'll see. Okay, it will also tell you about the percentage of neoplastic cells, but sometimes the percentage of neoplastic cells what you see in morphology and flow may not match. Okay, there are multiple reasons for that. The decrease in percentage of neoplastic cells in flow may be because of hemodilution or loss of nucleated erythroids during processing. That is, you will be using a lysing solution, so that can eat away some amount of nucleated erythroids, and the percentage may be elevated because of this, or because of hemodilution the percentage may go down. Okay, sometimes you get higher percentage in flow cytometry, that is because of non-classical morphology. So I have seen an AML where the neoplastic cells are looking more like a myelocyte with granules, and as I hardly got some 6%, 7% blast, but when I did flow it was around 22%. So non-classical morphology is something which you can miss by morphology. Okay, so flow is very good in picking up those cases also. Now let's see some other set of cases. So this is another case where I found this particular morphology. Lymphoid, everyone agrees? Any difference of opinion? Lymphoid, 2 years female child, 2 years child. When something comes like that, first I would say more looks like a lymphoid. Okay, no granules, no or rods. Okay, then we did flow. Flow wise, yeah, this particular population, red, you see 45 is negative to dim. This is the neoplastic population, red in color. So negative to dim. So this, I suppose everyone knows the scatter. This is one among the universal plots, side scatter versus 45. So whenever you are analyzing a flow data, you need to draw 4 to 5 plots for all cases, which I call them as universal plots. Some people call them as, molecular people used to call them as housekeeping plots because they are more trained to housekeeping genes, so they call this as housekeeping plots. So these plots include forward scatter, side scatter, where you can exclude the debris and take up the live cells for analysis. Then you need to have a singlet gate. You need to have a time gate before that to ensure that you have a stable acquisition. And this important plot, that is side scatter CD45, which will give you a global idea of what are the populations there. So you find neutrophils here, monocytes here, lymphocytes here. You find the basophils, PDCs, these populations here, and of course this is the blast gate, which will have the blast. So this is the blast gate, including this basophil PDC. Is whatever comes in this area is called as a blast gate. So now in this case, you find a red color population which is 44% occupying a 45 negative to dim region, and these are all blast. So it is positive for CD19. It is positive for CD10. It is positive for CD34 in a variable fashion or in a dim fashion. It is positive for HLA-DR. I said it's negative for CD20. So here we have multiple things to confirm that this is immature. So CD34 is positive, 10 is positive, 20 is negative. So these are all confirms that this is a immature population. And you see cyto CD3 is negative. Okay, so the diagnosis is BALL. But BALL, what type of BALL? Could you further subtype it? IgM is negative, so it's more likely a Kala positive BALL. Of course, now after the WHO, this is not much useful, but still there are clinicians who ask, what type of BALL is that? Is it pro-BALL? Is it Kala positive BALL? Is it pre-BALL? So now also some people ask, because the prognosis differs between these cases to a small extent. Okay, so now this is Kala positive BALL. However, this is another case which is again had a morphology of T lymphoid blast, and we did flow. So this population lies exactly here, negative for CD45. Of course, now it is positive for 19. 10 is positive, but it's in a dimmer fashion compared to the previous case. And 34 is negative. So the earlier case it was 34 positive, but here 34 has vanished. It is not, it is negative. 10 is variable, dim positive, 19 is positive, 5 is negative. The myeloid markers are negative. And you have 10, so 20 is negative. And this is cytoplasmic IgM positive. And now this is again a B acute lymphoblastic leukemia, but this is a pre-BALL. Okay, this is pre-BALL. So flow can, apart from diagnosing BALL, TALL, acute myeloid leukemias, it can also help you to classify those leukemias. So as I said, BALL can be pro-BALL, common BALL, that is Kala positive BALL. It could be pre-BALL or mature B. Okay, so now what is the advantage of this is the prognosis. Pro-BALL has a very poor prognosis. It's like more comes in it is more common in infants, and it has a relatively poorer prognosis, and they harbor an MLL gene rearrangement sometimes. Okay, so these cases have a relatively poorer prognosis compared to Kala positive BALL. Okay, similarly pre-BALL has better prognosis than pro-B, but a slightly bad prognosis, slightly no, I should not say bad, relatively less prognosis than common B or Kala positive BALL. So apart from diagnosis, flow can also help you to classify that BALL. Okay, similarly this is a case of TLL where it is CD1A positive. So this is cortical BALL. So cortical TLL has a better prognosis compared to your early T cell ALL, which is ETP ALL and so on, so which has a very bad prognosis. So apart from diagnosis, I repeat, it can able to give you a classification of that also, whether it is pro-B, is it Kala positive BALL, is it pre-BALL, similarly in TALL, whether it is ETP ALL, is it cortical TLL, is it mature TALL. So flow can also help you to classify that particular lineage acute leukemias. Okay, so this is classic TLL where HLA-DR is negative, CD1A is positive, 7 is bright, it is 4 and 8 double positive. So this all will be very interesting when I take you through the ontogeny of T cells. Okay, CD3 positive in a variable fashion, 5 is relatively dim compared to the internal control. Okay, so this is normal green population, normal T cells, this is B cells possibly, and you see CD5 is slightly dimmer or low in intensity compared to the normal internal positive control. Okay, and one more thing, you can get aberrances. Okay, so here this population is showing a very dim CD79A in a very dim fashion. So you should not call these as mixed phenotype acute leukemia. Okay, there is something called lineage specific markers. Okay, which I'll discuss later. I don't want to dump everything now. So again, as we saw with BALL, TALL also can be classified based on flow cytometric findings. ETP-ALL, pro-TALL, pre-TALL, double positive and single positive ALL. Basically, double positive is cortical and single positive is mature TALL. And this is all immature, ETP-ALL and then early TALL. Okay, based on the phenotypic markers, you can able to classify. Now, this is a case where we found a blast which is positive for CD34. So, of course, it's acute leukemia. How to fit in the lineage now? CD45 is dim. It is variably positive for HLA-DR because this population is traversing from negative to the positive area. So, it's variably positive for HLA-DR. It is CD7 positive, of course, slightly on the brighter side. CD7 positive. And it is negative for cytoplasmic MPO, which is a lineage-specific marker for myeloid. It is negative for CD19. It is negative for cytoplasmic CD3. So which is again a lineage specific marker for T. So lineage specific markers are all negative. The blast is showing positive only to CD7. So what do you want to call this as? Anybody? I have interpreted the markers for you. Anyone wants to give a diagnosis? So this is a case of acute.
PPDCN markers were also negative, like 456 and all.
Excellent. Very good. Very good. Okay. Now PPDCN will not show variable. I completely agree with your diagnosis. That's a great diagnosis. But HLA-DR will not be variable in PPDCN, and getting CD7 in PPDCN
7 is also unlikely. Just
Perfect.
wanted to rule it out before calling
Perfect.
it.
I completely agree with you. I would definitely do. But now let me tell you, CD123 is negative, 4 is negative, 56 is negative. Now you tell the diagnosis.
Acute undifferentiated leukemia.
Perfect. That's great. So this is acute undifferentiated leukemia because you don't have a lineage specific marker or other. It's not fitting into other criteria. So now you want to put this as acute undifferentiated leukemias. Without flow, these cases cannot be diagnosed. Okay. So that's beauty. And to do this FAB typing, you definitely need flow. Okay, starting from M0 till M7, you definitely need flow to put your acute myeloid leukemias in any one of these criteria. Without flow, you cannot subtype it on this. Okay, of course, now this classification has gone and we are more relying on this particular classification, but still, to diagnose it as acute myeloid leukemia, you need flow, and to fit into one of these categories when all other things have come negative, you need flow. Certain rare cases like acute basophilic leukemia, and erythroid leukemia will be diagnosed by flow, not by any other modalities. Okay, so apart from diagnosis, to classify the leukemias, if you want to classify B-ALL into Kala positive, pre-B, pro-B, similarly ETP-ALL, cortical T-ALL, mature T-ALL, and myeloid leukemias into M0 to M7, you need flow cytometry. So apart from diagnosis, for classification, you need flow cytometry. Now, let's go for another case, very interesting case, 2-year male child with pancytopenia and hepatosplenomegaly, and of course, very classical lymphoid morphology, right? Very scant cytoplasm, very condensed chromatin, and it is typical lymphoid blast. Okay, the question comes is whether B or T, what to say. So we proceeded with flow. So flow, again, the population was occupying a blast gate. Okay, and it is positive for CD19. It is negative for CD10. It is moderately positive for CD38. It is positive for HLA-DR, and CD15 is variable in fashion. It is positive for NG2, which is a marker, special marker. I'll tell you during our BLL classes. So anyone wants to give a diagnosis? You have a negative for CD10. You have positive for CD34. Let me tell you, other myeloid markers are negative. Other T cell markers are also negative.
2279.
CD79A was DIM positive. DIM positive.
22. I would still like to tilt towards B lineage then.
Okay, good. You want to be more specific?
NG2 positive, so KMT2A gene rearrangement should be thought of.
Super. See, this is a pro-BALL. Okay, whenever you are getting a pro-BALL is something when you have a BALL without CD10. Got my point? Because if you see the ontogeny of B cells, during the pro-BALL, 10 is negative, 19 is positive, other immature markers are positive. When it goes to Kala positive, it acquires 10. So Kala positive will be 19 positive, 10 positive. Again, I'm saying don't get panicked. This is a very fast class. I'll be taking in detail when I'm doing the next subsequent classes. Okay, so this is pro-BALL because it is 19 positive, 10 negative, and see, this is a classic signature for MLL gene rearrangement. NG2 and CD15. CD15 is a myeloid marker. When you are getting it in BALL, which is CD10 negative, always do NG2, or you write in the report that check for KMT2A, okay, which is earlierly called MLL. Okay, so this is a pro-BALL and this is MLL gene rearranged, that is KMT2A gene rearranged pro-BALL. Okay, so flow can also give you an idea about the molecular rearrangement which is present. Okay, so we did with cytogenetics and we used a break apart probe. and this was turned out to be MLL rearranged. You can see that this is a normal signal, and you see this is MLL rearranged. So the probes are split. The signal is split. In normal cell, in normal like MLL gene, which when it is in normal fashion or in a wild fashion, it should be like a fusion pattern. Here it is split. So this is MLL gene rearranged DLL. So flow, not only in this case, many cases flow can help you to give you a molecular abnormality. A classic example which we all know is APML. APML, though you get it by morphology, flow can also detect APML and it can give you about a genetic rearrangement, 15-17, right? So similarly, many such cases are there. So immunophenotype with bad prognosis. As I said, you pro-BALL, very bad prognosis. ETPALL, very bad prognosis. RAM phenotype AML. There is a subset of AML which is called RAM phenotype AML. I'll discuss during AML, okay, AML lecture. So these cases have very poor prognosis. APML, when it is expressing CD56, it has a relatively poorer prognosis compared to cases which does not express CD56. And similarly, CLL cases, when they express CD38 and FMC7, they have relatively poorer prognosis compared to cases which does not express this marker. Okay, so it can help you to give you the prognosis of the case. Flow can also add light apart from diagnosis and classifying. It gives you an idea about the prognosis, how this case is going to do in the future. And as I said, FCM can also predict genetic abnormalities. Okay, now the case what I showed you was MLL rearranged. Okay, similarly in AML, it can be able to detect translocation 821 when the blasts are apparently expressing CD19. Okay, similarly APML I said you, and when AML blast or myeloid blast is HLA-DR negative, it is most likely NPM1 mutated, provided you have excluded APML. Okay, and similarly when blast is expressing CD25, a BALL or a B lymphoid blast is expressing CD25, it is pH positive likely, and you need to do Philadelphia, especially in adults. Okay, it could be pH positive BALL. This one we saw. So, and we can also do ploidy by flow cytometry, and you can say whether it is hyperploidy or hyperploidy. So you know BALL with hyperploidy has a good prognosis, and BALL with hyperploidy has a poorer prognosis. Similarly, in myeloma also you can do ploidy analysis by flow. You see, some people may ask me, what is the advantage? See, since you want to do everything in flow, would you put everything into flow? See, there was one case where we got the sample. The blast percentage was very small. It was hit by steroids without diagnosis. The case was hit by steroids from outside, and the case was referred to us. The blast was just, I suppose it's around 1% or on a 0.9%. And then you can't do cytogenetics in such a sample because out of 100 cells, only one cell is an abnormal cell. And if you do cytogenetics, it's not such a sensitive technique. Since 99 cells are there, it would either show it will most commonly show a normal karyotype. But now by flow, I can able to pick out that 1% disease, and I can see ploidy in that. Okay, so that is the beauty of flow. So it can also help you to do ploidy by flow cytometry, which is called flow cytometry ploidies. Okay, and it can also help in risk stratifying the case. As I said, BLL with high risk is pH positive BLL. pH like BLL, we have some markers for pH like CRLF2. Okay, so that is pH like ALL. ML rearranged, I just showed you. Hypoploidy, I told you. And there are some cases which you can solve. So of course, this is something like this can't be done by flow cytometry. But the other cases, yeah. So flow can help you in risk stratifying the cases. So apart from diagnosis, it helps you to classify the leukemias. It can also help you to predict the prognosis or risk stratify the cases. So that is great about flow cytometry. Now, the same case which I showed you, that is KMT2A rearranged DLL, 1 month passed, and now the case has come to me again for post-induction assessment. So you know phases of acute leukemia treatments, you have induction, consolidation, and then you have maintenance. Okay, so induction is something like they hit the tumor or hit the neoplastic cells very hard, so that they want to decrease the tumor cells as much as possible to maximum log reduction. Okay, so this case, a post-induction which is normally given for 28 days was given, and then the case was sent to us. So bone marrow cytology obviously showed no increase in blast. There were only normal cells, and then we did MRD assessment. So what is MRD? MRD assessment, basically MRD is minimal or measurable residual disease. That is, you diagnose a case when the blast is around some 90%. Then they go for treatment. basically an induction treatment which takes around 28 days where hit the tumor very hard. Now this 98% will drop down to somewhere around 1% or 0.1% or 0.001%. So the tumor may go so low, and this tumor will be hiding behind a normal hematopoietic cell population. And by morphology, by fish, by karyotypic, you cannot pick up this population. You need a very sensitive technique to fish or catch it up that particular 0.1% neoplastic cells which is hiding. You can do it by flow cytometry, which is called MFCMRD or flow cytometry based MRD, multiparametric flow cytometry based MRD, or the other technique is by molecular sequencing. Okay, molecular is much more very demanding because during the initial diagnosis you should pick up the molecular signature of the blast, and then you need to search it during post induction. Whereas flow, it's not the case. Even if it is baseline phenotyping is there or the baseline immunophenotype is there, it's good. Even though if it's not there, I can able to detect it by TFN approach, which is different from normal approach. So this all I'll discuss again in MRD. So again, I'm reassuring. I am showing a glimpse of everything. So certain terms may be new to some people. Please don't be afraid or panic. I'll definitely deal all this more detail during the subsequent sessions. Okay. So this case after induction came for MRD assessment. Okay. So why you need to do MRD is that, see, here you diagnose the case as acute leukemia, and once the treatment is given, it will go to this percentage. That is, the tumor or the blast will go to from, say, like example, from 100% or some 10%, it goes very low, less than 0.001%. Okay. Now, if you just see by morphology and you say there is no increase in blast and they just continue with the same treatment, okay, there is a chance like if the treatment is not effective, there is a chance like these blasts can proliferate and come out as relapse. And whenever a case relapse, the diagnosis is going to be very bad. Okay, but what is the MRD detection? What is the advantages? You have a diagnosis, and after induction, the tumor load goes so low, and when you use a sensitive technique like flow cytometry to pick up the residual disease which is present after treatment, and if it is positive, you can augment the therapy. You can make your therapy a much more stronger, something like a reinduction or to adding one more chemo agent to the continuing therapy. Now, this slowly rising population will again be controlled, and there's high chances that the patient can go for remission, and it will not be relapsed as we saw in the earlier case. So, if you do MRD at regular time points and make sure the tumor is not popping up or not again creeping up, okay, that is very good. You can continue with the same treatment. But by chance, if you find that the population is slowly coming up and you find a residual disease by a sensitive technique like flow cytometry, you can augment the therapy and you can avoid relapse. And you can take the patient for remission or other procedures like bone marrow and take up for bone marrow transplant or something like that. Okay, so that is the advantage of flow cytometry. It gives you a personalized treatment. Okay, so yeah, out of 100 patients giving a standardized protocol for all 100 patients, I now split the patients into two groups. The patients who have responded well and their MRD is negative, so let them go through the same protocol what has been designed. And the other set of patients who are MRD positive, that means the treatment has worked but not that great that it has eliminated below the cutoff. Now these patients, they will augment a bit treatment and they will try to bring it MRD negative, and then they can continue with the same treatment or they can take it for some other procedures like bone marrow transplant. So that is the advantage, and flow helps in detecting minimal residual or measurable residual disease during the phases of treatment. Okay, so this is the same image what I'm showing you. So this is the diagnosis, and when you don't have MRD, it can go for relapse if the treatment is not working, and this shows the depth of doing it. Okay, so you have different techniques. So morphology, when you find you can detect the blast when they are a percentage of 10 to the power minus 2. Okay, fish, it is 10 power minus 3. IPT, you see IPT, it can go up to 0.001. Okay, so that is the beauty of IPT. So this is 1%, this is 10%. Okay, so flow is very useful in doing MRDs also. So doing MRD is something like searching for a needle in a haystack. It's very difficult. By morphology or other insensitive techniques, it's very difficult. But if you use the right tool, you can catch it up. That's the beauty. Now this case we did the same case, coming back the case what we discussed, KMT2A rearranged BALL or MLL rearranged BLL. We did flow for MRD detection, and when you are doing MRD, you need to acquire large number of events. High acquisition has to be done. For diagnostic, if it is 50,000 or 1 lakh, it's fine. But when you're doing MRD, you need to minimum acquire 1.5 million events. So we acquired and we found that the residual disease is positive, which is 0.06%. Okay, now this is MRD positive. Still you can find the residual disease there in the marrow. So the treatment was augmented, and then the patient was subsequently turned out to be MRD negative during the consolidation assessment. This is an induction assessment, and the patient was taken through a consolidation, severe consolidation with an extra drug, and he was found to be MRD negative at the second time point of MRD assessment. So apart from diagnosis, classification, and risk stratifying, it is also used for follow-up and assessment of response. So flow is helpful in these also. Okay. Finally, now we have come to an area where we are giving very, very specific treatment for everyone. Like it's a personalized treatment. And now we are into the zone of immunomodulation or immunotherapy or cell therapy. So immunotherapy is like you give monoclonal antibodies against a target antigen. Cell therapy is like where you use our own cells to kill the neoplastic cells. Okay, so in these areas, flow is indispensable. Okay, so some of the immunotherapy which we commonly know is rituximab, which is anti-CD20. We have inotuzumab, which is anti-CD22. We have this gemtuzumab and osagamicin, which is CD33, 38 daratumab, 52 CD19, which is blinatumab, and so on. So now these are all coming up in a big way. And if you want to give this drug, okay, so you need to check whether the tumor cell is expressing these particular markers. See, if I want to give rituximab, which is anti-CD20, first of all, I need to check whether the blast or the neoplastic population is expressing CD20. For example, let me tell you, CLL, chronic lymphocytic leukemia, will show CD20 in a very dim fashion. Whereas mantle cell lymphoma shows CD20, expression of CD20 is good. So, in which case rituximab works very well. Definitely mantle cell. Not so effective in CLL because 20 is dim in CLL. Whereas in mantle it is moderate to bright. So rituximab binds to CD20 and kills those cells more effectively than the CLL cells. Okay, so to find that expression of these target antigens, you need flow cytometry. Okay, and similarly CAR-T therapy. CAR-T therapy, how effective it is it doing its job? Is CAR-T therapy what we infused is still in circulation? So what is CAR-T therapy is again a big topic. CAR-T therapy is something like you take your own T cells, genetically engineer them against one particular target antigen, and then you re-infuse that particular cells into the patient. Okay, so under this CAR-T therapy, again it is again CD19 CAR-T cells are there. So now currently anti-CD19 CAR-T is widely used. So these cells can be monitored by a flow cytometry, and its effectiveness, whether it is killing the 19 positive cells, can also be checked with flow cytometry. Okay. So as I said, when MRD is positive, you can augment the treatment and you can subsequently give a personalized treatment for that particular patient, specific to that patient. So these are some of the antigens against which immunotherapy is available: CD20, CD52, which is called alemtuzumab, CD19, which is a there is blinatumab, which is basically a bispecific T cell engager, blinatumab, which targets 19. You can use CAR-T therapy where the T cells will go and attack the CD19 positive cells, which is called CAR-T therapy. CD20, I told you, anotuzumab. Okay, so these are all some of the agents. So I'll just give you an example for that. This is patient A, this is patient B. Okay, now this particular patient, okay, is expressing, it's of course an acute leukemia. It is expressing CD19, 22. It is expressing CD10. It is negative for CD34 or dim positive for CD34. It's negative for myeloid markers. So it's a case of BALL and expression of CD22 is positive. Now if I'm going to give anti-CD22 for this case, it will be effective. On contrary, you will find this case where CD19 is positive, 34 is positive, but 22 is in a very, very dim fashion. In fact, most of the tumor cells are negative for CD22. If I'm going to give anti-CD22 in this patient, it may not be as effective as it was for this particular patient. Okay, so that is the beauty of flow. It can also help you to select the treatment what has to be given for the patient. Okay, so apart from diagnosis, classification, risk stratification, follow-up, assessment, it also helps you to select a proper treatment and a personalized treatment for every patient. Okay, that's the beauty. Now, summing up everything and coming to the closure of today's lecture, the advantages of flow cytometry include its rapidity. You give the sample morning, you can give the report by evening. No other technique can give you so fast reports. Okay, you can study multiple markers across any combinations. Okay, immunohistochemistry, you can study only one marker at a given time. But flow, if you have a 13 color flow cytometer, I can study a combination of 13 markers on the neoplastic cells. That can be done by flow cytometry. I can find a small subset population. As I told you, see, we had a case where 98% of the blast was negative for a marker. Okay, the treatment was given, the patient relapsed after 6 months, and at that time when we did flow, we had a completely different immunophenotype. We were saying, like, how come that's possible? During the initial diagnosis, the phenotype was something different. Now it's completely different. So we went back and saw the baseline, the initial phenotype, initial flow. There was a 1.5% small population which was there. Now what happened is that the big tumor clone as sensitive to the chemotherapy given and it has regressed. Whereas the small clone which 1.5% was there, it was insensitive, and now this has expanded and caused the relapse. So it can identify small subset population. No other technique can identify that subsets. Of course, fish can identify when the tumor is greater than 1%, but flow can identify even smaller populations than that. It can identify MPAL, that is mixed phenotype acute leukemia. It can identify ETP-ALL, which has a very poor prognosis. It can identify RAM phenotype AML, which has again very poor prognosis. So these diagnoses can be made only by flow. Okay, and you need flow indispensable for making these diagnoses. Okay, as I said, it predicts genetic abnormality. It gives information on ploidy status, and it is very, very, very useful in MRI assessment. Okay, so these all will be covering in the subsequent lectures. This lecture, I just want to take you through how flow is useful in hematological malignancies. Let it be leukemias, let it be lymphomas, let it be myelomas. Flow is very good, and it is very, very, very useful. Okay, so with that, I'll just close today's class because we have a lot more from next week. So keep yourself free this week. Next week, we'll have much more to entertain. Any doubts? So there are some doubts. So can hematogones be seen in peripheral blood? Yeah, very rarely, but morphologically you cannot find it. And if you are acquiring, say, like around 5 million events in peripheral blood, you may find some hematogones there. Yes, when stem cells are coming out, why can't hematogones come out? It can come. So you should be very careful of it. But if you are finding, say, if you are finding 3% hematogones, then there is something wrong. It could be acute leukemia, you do a marrow. But if you find hematogones in 0.1% or something like it, still it could be hematogones, yes. Any other doubts?
Sir, I am Dr. Rezan Rahman from Bangladesh.
Hi, sir.
Sir,
Yes.
hello. As we are working in different places, so sometimes these lectures we miss due to some reasons like our chamber or our duty. So if these lectures in this group, your video lectures, so will helpful.
Yeah, sir. But it will be available by default, sir. We have this classroom where these lectures are available on a recorded platform.
Okay,
So
okay.
you can have access to them anytime when you are feeling free.
Okay, thank you so much.
Yeah. How panel be designed? Panel designing, basics of panel designing, we have already seen in our basic flows course. Regarding these specific ALL lymphomas, we'll be discussing in the subsequent lectures. Okay. Any other doubts? Dr. Arivarasan, any doubts? You are there?
Sir, yes, sir, live, sir. No, sir,
Superb.
no, I'm clear.
No doubts. Excellent. Superb. Okay, we have a doubt. How to understand positive and negative markers from tracing? What is tracing? I'm not getting. Dr. Menas, can I have more light on that question? how to understand positive and negative markers from tracing. I'm not getting that word. Tracing. What is tracing?
Hello.
Yes, doctor.
Tracing means the chart from the chart the x from the x-axis and y-axis, and I have seen here 10 to the power 4, 10 to the power 5.
Yeah.
How we can understand when it is positive from the scattered
Yes. So
scattered markers.
Yeah. I'll tell you what.
Because I didn't have the basic course, so I'm not.
Yeah, I'll tell you. No problem. See, if I can't go very detailed into that because, but I'll tell you what. Never go with scaling. Don't say this 10 power 1. Anything beyond 10 power 2 10 power 2 is positive. Anything beyond 10 power 3 is positive. No. There could be autofluorescence where the population is lying at 10 power 4 and still it could be negative. How do you do or interpret a marker positive or negative is based on, as I showed you, is based on internal negative and positive controls. Only with that you should be able to say whether it is positive or negative. You should not see the scale. Scale is immaterial. Okay, because if you find an APML case and you put it across any markers, the abnormal promyelocytes will be mimicking like it's positive for markers in a dim fashion or a moderate fashion. That means that doesn't mean it is positive. It is negative. You need to interpret those markers with positive and negative controls. That is how you need to do it. Okay. Don't worry. We have much more plots to see. I'll tell you what. If you want, I can just. Should I tell you? Let me tell you. Hold on. I'll just show some plots to you with where there is a control. I want a good control to show you. Okay, not this. Even let us take much better case. Yeah. So now this is a case where you are finding the blast population in red. Now I do have internal control for CD19, which is my B lymphocyte, mature normal B lymphocyte, which is my positive internal control. This population, which is negative for CD19, okay, is my normal negative internal control, which is T lymphocyte. Now, if I want to interpret this particular population blast, whether it is positive for 19 or negative for 19, I need to see with these two internal controls. You see, this population is lying above this particular population. So this is positive for CD19. I never see this scale. This scale can mislead you. Okay. So that's how you need to interpret. You see CD45. CD45 this is normal population. Okay, which is bright.
So we have to always compare with the control.
Yes, sometimes your leukemia may be so florid that it would have eaten up all your normal population. You find a big chunk of disease alone, no internal control. At that time, it may be a bit difficult, but such instances are relatively rare. So you need to interpret all your markers based on internal controls. And basically, those internal controls are most of the times lymphocytes, and sometimes can be monocytes or neutrophils. Neutrophils can show autofluorescence, so mostly lymphocytes or monocytes and erythroids if you are, yeah. Right. Any other doubts? No other doubts? So with that, we have a lot to go. We have 3 months to go together. So I'll close the session. So next week, Wednesday, we'll have BALL session followed by Thursday where we'll see live analysis. If anybody wants to contribute your cases where you have a BALL cases which you have a diagnostic difficulty or you felt interesting or you felt want to share it with other people, you can give me such cases. I'll take it up during our live discussion.